Well, hey, welcome back. My name is Matt Bobman. I'm the organizer of ACL Study Day. This is our third session this morning for live question and answer sessions. So if you happen to catch our first two sessions, that's great. We had a couple of our presenters in the morning, and then we just finished up a patient perspectives Q&A session, which was really great. So I would encourage you to go back and watch those. But right now I have three of our excellent presenters from ACL Study Day joining us to answer questions. So Julie, Susan, Dustin, welcome.
Thank you.
Thank you.
Before we get into questions, I would like you three to just give us a quick introduction and tell us about your work. Tell us what you're working on. Julie, why don't you start us off?
Sure. Julie Eibensteiner. I'm a physical therapist out of Minneapolis, Minnesota. I own my own practice, Laura's Athletic Rehab and Performance, which was it's a facility that's physical therapy mainly designed to focus on ACL injured athletes, and then a sports performance component of that. Often they both go together. This facility is going on its 11th, or my practice is going on its 11th year, 7th year in this facility, and then I guess kind of a niche, or something that's a little bit different about me. I'm also an assistant coach for was a Division III program. We're now moving to Division I women's soccer program. So I have that perspective as well.
Go ahead, Susan. Tell us a little about you and your work.
Yeah, I'm Susan Sigward. I'm a physical therapist and athletic trainer. I practiced a while ago, back in the day. I don't want to reveal any ages here, but I practiced for about 10 years before going back to school and getting my PhD in biokinesiology at USC, which primarily with a biomechanics emphasis, and have been doing research in that space, originally looking at biomechanical factors related to increased risk for ACL injury, and probably over the last almost decade, looking at sort of biomechanical markers related to recovery after injury.
Dustin, go ahead. Who are you?
Sure. So I'm Dustin Grooms. I'm a professor at Ohio University in the Division of Physical Therapy. I was a practicing athletic trainer about a decade ago now, and I didn't plan to do a PhD. I got into PhD studies mostly because I was a little disappointed by the therapies available to me and the outcomes that we were having, even though we would throw everything we had at them. And then I ended up going to do a PhD at Ohio State, where I started in biomechanics, and then I switched to neuroscience. And so now I study how the brain changes after injury and what we can maybe do to fix it.
Excellent. Well, I think we can get right into some questions here. The first question is for you, Dr. Segward. Can you give us an example of a constraint-induced therapy used during a double limb squat?
Wow. We're coming out punching. A constraint-induced therapy used during double limb squat. Well, I mean, there's a lot in that question. When you bring up constraint-induced therapy, you're actually talking about the idea of learned non-use in the upper extremity, which is sort of the foundation of much of the premise of how we're trying to relate underloading and persistent underloading in the knee after ACL reconstruction to this idea that you can use this in some circumstances. You have the ability to use it, but in those sort of submaximal tasks, the individuals don't appear to be choosing strategies that use their involved knee or their mostly sagittal plane and knee extensor. So it's not an easy paradigm to translate directly, because in the in the neuroscience world, when you said they're not using their surgical limb, their upper extremity, unless they somehow tether their good arm and make them use their hemiparetic arm. So in the lower extremity, we can't really do that. We can't just tell them to not use their other leg. And that's kind of why we sort of adopt this terminology of underuse versus non-use, because you're always using your limb, but you're not using, individuals don't appear to be sort of incorporating their knee as much. So I don't think I have an example of that, to be honest with you. I think think that if you were to apply that to attempting to identify an exercise that would constrain the other joints, right? Oh, am I having connection problems?
It's okay. We can hear you.
Yeah, and I can pop in too if because your audio is a little on and off. Okay. Just to piggyback off of that, I do a ton of split stance, single leg work, and a lot of open and closed chain work. I would probably say maybe 30% of the overall rehab, if you were to look at a typical 9 month rehab, I would say probably about 30% of the activities and exercises that I do is just strictly on a bilateral stance, which I think is what's maybe this question's getting at a little bit more. So we do a lot of split squat, split stance. I'll do some. I have a force plate where I can do a force vector overlay, where they can get some visual feedback of kind of where weight shifting is at live. Which, in all honesty, I used it a lot more when I first got it, and use it a little bit less now. But I think a lot of getting them onto one leg and actually forcing them a little bit more into that disuse or underuse, and trying to trick them into ways where they have to be on that leg a little bit, but it needs to be within a reasonable amount of challenge. If it's too easy or if it's much too hard, then you're just going to feed. I think you're just going to feed the compensation a bit more. So you just kind of find that sweet spot where there's a bit of a struggle. Lots of feedback. I use a ton of video, just showing them, what maybe a hip dominant or a quad dominant or more of a balanced strategy looks like visually for them, and let them try it again. And then a big one, if it truly is quad strength is the issue, and that's why they're off shifting. I use a ton of open chain stuff. It's something I've changed a lot in the last 5 years, because just on something as simple as a single leg knee extension, there's really no way to cheat around that. You're forced right into using it, and there's a ton of great feedback. So that's what and you got to kind of manage, is it a fear thing or is it a weakness thing, or is it both of them? Because a fear thing can look a lot like a weakness thing and vice versa. So just kind of managing the athlete with that. So hopefully I got a part of that, and maybe Susan got her Wi-Fi working a little bit better too.
Yeah, I hope. I don't have any solutions here. Am I working?
Yeah, it sounds
you sound fine.
Okay. Yeah, and I think a lot of those from a clinical perspective are, the way to be targeting this. But I mean, unfortunately, I think that we're pretty good at compensating regardless of what situation we're put in. And that sweet spot, I think, is really important, to be trying to figure out what demand are you giving them that they're not that they're not trying to not use their surgical knee. And I think that's really hard to be able to identify too when you're just observing something. So I think there's a challenge there. There's a challenge where we want to continue to use these compensatory strategies regardless of the demand that we're imposing on them.
The best athletes are the best cheaters too. I've found with gymnasts, they can look like they're completely using both legs equally, and then you put them on a force plate and see what really is happening, and oh my gosh, yeah. So, and I always tell athletes it's a compliment because you're finding ways around the problem, but it's a problem.
And that's really highlighted in some of the stuff that we were looking at as far as shifting to the other limb. And that's why I think I like force plate technologies and being able to determine in a double limb task, are you using the other limb? Are you shifting to that other limb? Are you shifting off of it? But but we found that that's not the only thing they're doing. They're making these very subtle changes in where their center of pressure is, which is distributing the load across the joints differently. We're seeing this happening, no differences in flexion, ankle dorsiflexion, and that's where I think we get this really, this challenge. How do you even identify that in the clinic? How do you identify that they are shifting off of the knee, not the limb? In fact, in a series of studies that Matt Chan did, he looked at, how do they load their limb when you have them do something fairly simple in a natural condition. So it's just standing up from a seated position. And he went through a couple different tasks and found that obviously they could do this stuff, but they didn't, and we were sort of deceiving them. In a follow-up, he had them. They had them with feedback or concentrating on equal weight and how they load their limb. We looked at some of the actual joint level data there more recently, published it, but we found that they can load. They do improve their limb loading, but they don't improve their knee extensor loading in this pretty simple task. And really, that's just one task. It's one, sort of looking at it versus, what you're doing in the clinic across a variety of tasks. But I do think it highlights this very special skill we all have, and probably more skilled individuals have in not doing what they should be doing, where we want them to do.
I don't know if this would qualify as constraint induced, but I really like Julie's example of using the water bottle, and where you're basically, if you push hard enough, you're going to squirt water out of it, so you're going to be forced to use one limb. And so I don't know. I think that was really great.
And that was with a 7th grader, and it made the most sense to her. Nothing else. There was no cueing you were going to give her otherwise, except for don't push the water out of the water bottle. It was magic.
Yeah, that's
I wonder
great.
too, Julie, do you? And I know you talked about using a lot of external focus.
Yep.
Do you have any sort of instructions to attend to, or maybe early on, attend to the quadriceps, engaging the quadriceps, or using your knee more when they are, sort of subconsciously cheating?
If it's very early on, like within the first week of post-op, I actually use pain as a good sign that they're engaging their quad. Then explain to them, a little anatomy lesson, and explain, that the muscles are, that's a good sign that you're engaging that quad. And so I tend to frame pain a little bit differently within reason, obviously. And then it's a lot of, just small, like, I don't want to say tricks, but yeah, just setting them up into different, like I said, I as far as offloading from one leg to the other, I try not to put them in, I don't do a squat before I do a split squat, even if they're like post-op. And then it's a lot of cueing of pressure through the ball of the foot, driving the knee forward, getting more of a positive shin angle, talking about upper body position a little bit, some of the things that you can't get at everything, but trying to just get the lowest hanging fruit to start with. Those are the big things, I guess. And then just the activity selection. But I try to talk more in analogy, more in simple cues, to try to get them to just kind of automatically process stuff themselves. So I don't know if that answered the question, but.
Yeah. All right. Well, here's a good question, I think, for Dusty here. So there are studies using TMS to promote plasticity in the chronic stroke population. Does this method have an application for the ACL reconstructed population?
Potentially. With TMS, it's a little difficult to do because you need someone who's trained in it. It's a bit of a technical intervention to do. There is a group at Michigan who's using it to do operant conditioning, where they deliver TMS in a way to encourage recovery of quadriceps activation, but that's a pretty controlled laboratory study. You are seeing it used a lot more in sports performance to enhance time to task failure and reduce fatigue, and potentially help decrease the level of inhibition at the motor cortex level. And so this would be a tool called TCDS, or transcranial direct current stimulation, which isn't the lab-focused heavy magnet tool that requires a lot more training. TCDS, you can purchase units, and it's basically like a low-level battery that basically just is supposed to raise the excitability of whatever's underneath it. There's some debate as to its mechanisms, but it seems like basically it could make it a little easier to generate a muscle contraction. And so in your patients that are really struggling with quadriceps inhibition, it probably couldn't hurt them. But I mean, I would say it's definitely not at a place evidence-wise where you would recommend it globally, and it's sort of at a use at your own risk stage.
Okay, I think I've seen these units where they, at least the anecdote says that they're gonna, like improve, like they took people who are doing shooting practice and they put the thing on, and then for like 90 minutes afterwards, their accuracy is improved. Is that kind of the same idea?
Yeah, that's the TCDS version where you don't really feel it. You might sense it a little bit on your scalp, and there's some debate whether you're just increasing general afferent traffic into the nervous system by exciting the afferent neurons underneath your scalp, and that just make the whole system a little more excited, and it might not be quite as targeted. But it does seem to have these big effects, mostly in the fine motor control for accuracy and to speed up learning. But there is some data that kind of goes the other way, that you might actually develop a bit of a crutch for it, where you're going to need that extra stimulus in order to function. There was actually some interesting stuff out of, I think it was South Korea, where people were hiding them under like baseball caps to play games because it would increase reaction time, they thought. And then when the guys were without it, though, they said they felt slower. So it might not be something you want to jump to or use a lot. But usually the fatigue or the precise motor control are the benefits. I haven't seen one where you've used it on a highly quadriceps inhibited population, ACLs, yet, but that seems to be like the obvious next thing to try.
Yeah. And maybe your students will all start showing up to class ready to learn wearing their TCDS headbands.
Dustin,
go ahead.
I was going to say, do you feel like, some of the changes that you can have through different other, a little more simplistic modalities are just as beneficial or profound as, finding some internal modality to enhance learning?
Yeah, I would probably just change how I deliver feedback. Like a lot of the things Julie talked about in her discussion were a lot of really clever ways. This is the cool things about ACL Study Day is once like clinicians get a hold of information. I wish I knew when I was a clinician what I know now. And when people just get this foundational idea, the creativity just goes through the roof, and people come up with all these crazy ideas. So I think I would maybe start with just how we deliver our therapy as opposed to jumping on like an unproven technology. The companies that sell them, like the Halo lens, that's the headphone thing. I mean, most of their claims are kind of junk. And so I would just be hesitant to jump to that as the solution. Because I would say the TCDS literature, it's very mixed. And there's a lot of people working on there's some people who there's some really good basic science that says the alternating current, which is what some units use, doesn't even penetrate the skull. And so some of the claims and the mechanisms for it, I just think it's more debated than people realize.
I think the what you hit on with the dependency too of technology. I think especially with a younger population, and so if we're not dealing with professional athletes, especially with high school, college athletes, the population I see, everyone's looking for a quick fix all the time. And I think part of the problem, especially with the second injury, is we're not rehabbing the first injury well enough. And it requires work and a lot of hard work. And I've seen it before where people get so stuck on the gadget they're using that they think it's the magic solution. And then all of a sudden they got a problem later on too. So yeah, that's super interesting to use. Or to look at how that might play a role to supplement some stuff, but you kind of saw it with BFR when that first came out. Then all of a sudden people are using BFR for everything, where it should really be something that's complementary to what you're doing, not the main course. So, but just I think we got to put the keys to rehab in the hands of the athlete and really give them the majority of the ownership. With my discussion I was talking about, we're taking this road trip. They got to drive the car, you know, and we can give them tools along the way. But I think the lowest hanging fruit right now for a lot of these injuries are we got to load them up better and give them ownership over their rehab so they don't feel like they're dependent on some of this other stuff coming up. I'm old school though. Yeah.
Well, I'm reminded of a Q&A that Dustin did with Lindsay Lepley weeks ago. Dustin's done more Q&As, I think, than anybody. But I think I asked him about injury prevention programs, and it was like, yeah, actually they're all pretty good. The hard part is getting people to do them. Like that's the basics, right? It's like, yeah, if you can do them, then they'll probably help you better than what a lot of people are doing now. Okay, I have a practical question about loading. I think all three of you could maybe have some input in this. So would starting off prehab or very early rehab by talking about decreases in daily loading help? Like, do we want people thinking about this? Do we want to bring it to their conscious attention?
I don't know if I understand the question appropriately, meaning that we should tell them to decrease or that be aware that they have decreased their load.
I think more like be aware, like, hey, this is a common pattern that we see after an ACL injury. You're going to have this surgery next week. I want you to be aware that this is what people tend to do naturally. Now, do we want them thinking about it? Do we want it brought to their conscious control? Is that an effective strategy?
Yeah, I think, you know, when we started looking at their daily loading, what they were doing throughout the day, and that's motivating a lot of the stuff that we're looking at now, is that my research lab was in the middle of a big clinical center, and there were these twin female soccer players that both tore their ACL within, you know, a month of each other. They're both rehabbing, and I was standing outside the facility taking a call, and I've been watching them through this. You know, they were probably 3 or 4 months after surgery. We see them in the facility working. So we were watching them through, and they look good. In fact, I think one of them had just had an assessment in our lab. We looked at them. They look good. They did a squat. Their gait looked good visibly. I was on the phone, and they were walking out of therapy, and they took 3 or 4 steps out the door, and then all of a sudden they're limping. I watch them get into their car, and not like in a painful way, but just maneuvering into their car. They're just hopped in on their good leg. They didn't use their other leg, and it struck me that outside of this focused attention in rehab, that that it's going to be more natural. Fear, protection, whatever it may be, it's less efficient to be using that leg, that they're gonna go on their way. And I have to think that sort of instruction, or that sort of awareness that, hey, you need to not just be favoring your leg all the time when you're not in here. You need to be incorporating it back into what you're doing when you're getting up out of your chair or whatever, going up steps and down steps, using it versus your other leg. I have to imagine that instruction or that counseling can't do anything harmful.
I'm super intentional on that, and because I deal with a lot of a high amount of, almost predominantly an athletic population, young athletes, all athletes understand, hey, you're not going to get better sitting on the bench at practice. You have to practice, and I always tell my athletes, you have to let that side practice, especially in all the times you're not paying attention to what you're doing. So I guess I'm pretty intentional right away from that first post-op visit, of provided they don't have any post-operative restrictions, of like, hey, you need to start using that. We want your body viewing that as your, not your surgical leg, not your bad leg, it's your right leg. The right leg and the left leg, you got to let both of them practice if you're going to get back into sports. So that's a seed I plant super early on things. And then the other part, I really encourage activity. So the first week, yes, let's get the homeostasis of the knee. But even with that, let's not just sit on the couch and let everyone just, go get everything for you. let's be independent in our rehab and have some ownership over rehab, and still try to be active. And then my home exercise programs, I mean, it's 4 to 5 times a day early on in that first week. They're short, but so they're not spending a ton of time just sitting around where it's just like, oh, I got my rehab exercises in for the day and then I'm done. So I try to bridge that gap a little bit more. And then again, it's the words you use and the phrases, how you frame that the first couple of weeks to try to set the stage.
I have to imagine too that you go back to that sweet spot, and your patients that are going to go out, 6-8 weeks later, and they're like, hey, I'm feeling good, I'm going to go for a hike, or I'm going to be walking around more than I normally do, and at a certain point you're going to start to adopt a compensatory pattern if you're overdoing it in a sense with activities that you're not paying attention to. My recent PhD graduate was just looking at gait on a treadmill, and there's a point at which you increase the speed that they adopt a compensatory pattern. They didn't have any pain. They are, they're 3 to 5 months after surgery. They have deficits that are enhanced when they start walking faster. At what point is there an activity that enhances a compensatory pattern versus increases the load on the joint to have a positive adaptation?
I'm curious to hear from you, Dusty, if you think, from like a motor learning perspective, or I just think, if you're telling people to be conscious of their limb, I mean, where's the turnover between like this will have positive effects by getting to load it more versus this will put too much internal focus into their day-to-day movements?
That's a good question. So usually I try to figure out clever ways, kind of like the stuff Julie was talking about, to not give them as much focused attention on the knee joint, because you don't, that's not normally how we're supposed to ambulate. Like we don't look down at our knees or like think about movement in that way. So a lot of goal-directed movement like gait, your spinal cord and your motor cortex, it just automatically programs it. You don't have a lot of direct conscious attention like you would do for more fine motor skills. That's actually some of the reason why they think TCDS is more effective for those, to relate back to that other question, than restoring lower extremity movement, because a lot of it, so much of it is subcortically regulated. However, your point is a good one, that if you have these deficits, I mean, they're not just going to automatically resolve. And your nervous system is on purpose shutting down your quadriceps because it thinks it has a lesion in the knee and it's trying to offload it just because they're reconstructed. The nervous system doesn't know it's reconstructed because there's no mechanoreceptors there. And so it has no sensation. So a lot of times that inhibition stays because the CNS still thinks there's a lesion and it doesn't want to load the knee. And so you almost have to find ways to trick people to do it. I know this is a longer-winded answer. I don't have a great response, because you do need to recover the quadriceps strength and maybe avoid those compensations, because if you don't put focused attention on it, especially in their daily life, I think Susan and Julie's right. They're just going to use their hip or their ankle, and they may never get it back. So I think that's where you have to be a clinician and decide how much dose do you want them to stay in this attention zone where they may have to engage the quadriceps, and then when do you transition them out? And that's sort of where the art of physical therapy comes in, as opposed to like me just telling you this is the time you do it and this is how much you do it. This is why we're clinicians, and it's one of the hard things.
Well, I think that leads us to the next point. We talked about gait, and gait's an area where patients can get a lot of load and aberrant load as well, and which can have some really negative downstream effects. Like, what is I'd be curious to know, like, clinically, Julie, how are you assessing gait and how are you making changes? And then maybe what does the research say about something as fundamental as gait after an ACL?
What time frame are we talking about?
I don't know. Probably 12. Yeah, probably 8 to 12 weeks and on.
Oh,
when we can assume the the knee is a little bit happier, more able to tolerate.
Yeah.
When I think when the capacity for normal gait is there. Sorry.
Yeah, I'm doing. I try. I do a lot of it is just experience, because I don't have a direct way of. I don't have a lab. to measure stuff as well. So a lot of it is trained eye on stuff, which there's definitely could be some bias and some error on that. I try to set the stage really early in that first 4 weeks post-op. I use actually the first 8 weeks post-op. I use a ton of marching progressions on stuff, and then with focus away from their limb. Maybe they're holding a stick overhead. Maybe they're holding a med ball overhead. Just different stuff where they're having to pay attention outside of their body a bit more. And really, the biggest gait issue that people have is extension, and wanting to kind of get that ACL gait where they got the bent knee and don't want to fully extend with heel strike. They're hesitant they're hesitant to load that joint. Then they'll typically offload onto the other joint. The timing's off. So I use a lot of marching progressions early on. I use a lot of metric timing, the metronome, with some of that stuff. And then when I use the University of Delaware running progression, which I love. And then I typically put them on a treadmill only on return to running progressions. If the gait looks fine, the knee's quiet, quadriceps coming along by objective measures, everything else is starting to come along. On their return to running, I usually put them on a treadmill with about a 3 or 4% incline on it at first, to try to force them into loading the knee a bit more. So just because it's tough to run uphill if you don't bend your knees. So otherwise you'll get that like locked out stiff knee with gait, and then just looking at tempo, cadence, stride length, that sort of stuff. So I guess that's my cash-based PT non-lab way of doing it. and a big part of it then is just monitoring how the knee's responding to it. So
yeah, I think gait is complicated, really complicated. We're finding that it does not spontaneously recover. Gait is a semi-automatic task that we have hardwired, but in these individuals, it doesn't spontaneously recover. And I know the ACL sports studies were finding that even, you could say, we're looking at these people, they didn't really work on it in rehab, or they didn't do rehab, or the people who have these, continuous or persistent gait deficits just didn't do it right. But even in the ACL sports study where they met certain criteria into it, they obviously completed the rehabilitation. They've found that the gait deficits that appear there, continue in a lot of these individuals. So I think it's really tricky. It's been sort of the bane of my research existence is to figure out what is a good stimulus, and in going back to the treadmill, just increasing speed so you don't have this. It's an implicit increase in demand, which should be increasing the demand in that knee. We found some improvements, but you go too fast or increase it too much to a greater extent, then you're going backwards. So again, what's the balance there? What is the stimulus?
I have them self-select on their speed almost all the time. I try to give them within a bandwidth, but I'm hoping that and give them some, like this should feel comfortable, this should feel smooth. So I give them some cues that way to hope, and I'm hoping that will guide them in a direction that kind of finds that sweet spot a little bit more on their own, hopefully. But I'll tell you what's really tricky. You get the adolescent athlete who's trying to, maybe they're about to go through their growth spurt, or they just have, and you're trying to sort out what their gait was before they ever got injured, because it was probably wonky before then. And then trying to get them, that is that's a whole challenge in itself. So,
like a baby giraffe.
Yes. Pretty much.
Yeah. Do you see? Well, I was going to ask you if you see. We all have split belt treadmills in our clinics soon, in the future.
I don't know. Do you want them really? So actually, first of all, to Julie's comment, we found that the self-selected speed on the treadmill for everybody, not just people after ACL reconstruction, is a little bit slower than your overground speed. So and speed is going to roughly be equivalent with the amount of demand you're putting through the limb at least. And but that those at 3 months after their reconstruction, they got on the treadmill and they didn't they tolerated it pretty well at self-selected speed. And we increased it just by increments of 25% from self-selected and 50% from self-selected. And at 25%, they were going then a little bit faster than their overground self-selected speed, and they were able to tolerate that demand. So that seems to be tolerate, meaning they increase the load in the knee and in other loading variables without increasing the compensation between limbs. So that seemed to be a pretty good stimulus there. And I would assume then if their self-selected speed improves and you stay within that window, that might be a good window to be at. It was the increasing to 50% speed, so really getting them going is where they started to fall apart, and controls didn't fall apart. So, I think that may be a fairly good implicit modality, and the giraffes might just be retaining their giraffe mechanics. But the split belt is complex. You look at the mechanics on the split belt, and they're a mess. There is not, you're inducing a perturbation. So, and we went into our study thinking, it's going to go faster on one leg. So we're going to increase those demands and give you a good stimulus. When you really look at the data, you're increasing a demand by certain metrics, but it's messy. It's messy. And I don't know if that an intervention is going to be the best way to go, at least in early rehab. Maybe the complexity or problem solving of that in later rehab, if you still have persistent diseases, that might be appropriate. But we also found that these guys, they do retain the ability to, which we think with, looking at the central nervous system changes and everything, that they lost this ability and will never get it back. We have to really be specific from the neuro control side. But we found that they can adapt. And that doesn't make it's not that probably surprising, because their deficits are literally an adaptation to their injury. So, neurologically, they just adapted to something. So the foundations of being able to learn from exercises, and they do in rehab.
I try to, once they get through I usually go through the level 5 of the University of Delaware running progression. And once they get to that, because I'm dealing with so many court and field-based athletes, then I tend to transition them into a 30-yard tempo runs. We have a 30-yard kind of straightaway in our facility. But I'll incorporate variability of both mode and variability of speed. So I'll tell athletes, like, all right, on the 30 yards down, you need to change speed once, if not twice, in that 30-yard movement. So they might go from a jog to an acceleration to a walk to, an 80% effort on the way down, and then the way back, just to try to get them not into one speed all the time. And then I'll also do other ones where they'll change the mode. Maybe they're skipping, maybe they're shuffling, maybe they're walking, maybe they're doing high knees. So they're having to switch up strategies of their locomotion. And that, again, that's trying to see if we can play around so they're just not stuck in one, kind of internal problem solving. So they're not always just stuck into one, locked into that one speed to try to find that compensation. Again, that's just our form of PT to try to get at some of this stuff, because everyone's such a good compensator. But hopefully, and what I found, it tends to iron stuff out quite a bit more, at least to the eye. So that's just one of the ways I try to bridge the gap back into from the early running on the treadmill to then getting into more, starting to set the stage for more specific return to running activities for a quarter field-based athlete.
So, Dusty, you in your talk, you mentioned an ACL injury is sort of like a reset in neural efficiency. Could you kind of talk a little bit about that, and then maybe I'm curious to know, does that have other effects that maybe are unrelated to the knee, like changes in cognitive performance?
Sure, I'd love to answer that question. I do have one more for the gait,
Sure.
and then I promise to answer it.
Yeah,
What do
yeah.
you guys think of, especially Julie being a clinician, like in stroke, I've seen a big push where people are trying to do more in the field gait retraining. So you have this problem of dose, right? So they're with you for 30 minutes and you do focused gait retraining. You might do really well, but then they're going to have 10,000 steps without you, or 5,000, or however much it is. And so it's an order of magnitude more of them without you. So I've seen this switch where they're trying to do like simple accelerometers on the shank and the thigh. And then when like the speed of each one, they're using very simple measures of even if you just do each shank. And so because what you would see is your ACL leg, or in theory, I don't know if I've seen a study, but in the more impaired population, your hemiparetic leg would move a little slower, right? And they would give you a little vibration or a noise or something to try to get you to normalize your gait. You could do it for knee flexion, I think, pretty easily. They do struggle with their patients to do them when they transition from the clinical trial to the pragmatic trial, and they're trying to get it in the field. It's a little more of a struggle. But the initial studies were really effective because then they would have this dose where they're like all day, like the thing vibrates if they're not walking symmetrically. Do you think that could have a role in ACL eventually? And maybe it would go to some of Susan's work, where if you had that from 3 months to 6 months, maybe Chan's that bilateral unloading, maybe that starts to go away because they've normalized symmetry. What do you guys think?
I would love to see that. The other thing, not to steal away ideas, but I always joke with my patients, I'd love to have an insole in the shoe that would tell them if they're offloading their, just a normal daily life early on, if they're offloading that side. And maybe it gives them like a vibration in their shoe if they're on, whatever, however you want to make the feedback. But yeah, I think that would be super helpful. After I just said I don't like gadgets all the time. I like that one.
I mean, but even like knowledge of results later at the end of the day, just how much you did or did not offload. And yeah, we're actually doing some of that work with some in-shoe sensors. And I think that translation from the hemiparetic limb to the very subtle differences that we're seeing after orthopedic injuries is really tough because you're talking the magnitude of a couple degrees of knee flexion, excursion or angle, and we're not at that level yet to be able to detect that variable than to give the quick feedback. But the underloading throughout the day is one thing, and the fact that most of your activities that you're loading the limb throughout the day are going to be walking. Even our athletic population, you're just walking around all day long unless you're exercising. But yeah, that again is and we're actually trying to figure out what is the little nuance of why they're underloading in it, and it looks like it's happening in sort of in the heel rocker. They're adjusting their heel rocker mechanism, and along with what Julie's saying is they either keep it they keep it stiff. It's either flexed and it stays flexed, or they don't flex it. It's extended and they don't flex it very much. So I'm wondering if there may be a little bit of a feedback in shank angular velocity. We actually found was related to decrease in knee loading as a decrease in shank angular velocity in loading response. So. But it remains to be seen if feedback of that specific variable is something that they can then, incorporate it. So tricky.
Have the studies showing the unloading strategies, have they had a psychological measure along with them to see if, is it really strongly tied? I would assume it's strongly tied to fear or no?
So,
or you seeing it anyway?
Yeah, so these guys are 3 to 4 months, and we had them fill out everything. We have strength, we have, and actually this paper is coming out in JOR right now, or it's he published or whatever. We couldn't find the only metric that was related to underloading was strength. And when you looked at it, some of these guys had some pretty profound quadriceps asymmetries, and that's what really drove this relationship. But in a lot of our studies in the lab and during the day, daily activities, there are people who have good quadriceps strength but are still underloading, and there are people who have pretty profound deficits, and they have sort of symmetrical just limb loading. So that is certainly is a factor, but it's we're finding that there's just not a straightforward metric that is going to be like it's fear, it's it's strength. It may also have a lot to do with this sort of interrelationship between their activity level, right? So activity level, the efficiency, the types of activities they're doing during the day. Those are still things that we need to be sort of looking into, but I wish it was, you start out thinking this is going to be so straightforward, and then you're like, oh.
I do think the fear question was an interesting one, Julia. It just reminded me to look. I know Ryan's our wiki. Trained with Lynn at Delaware, is now at Arcadia. He did a cool paper where they looked at fear and gait loading asymmetry, and there's a few papers before him, like out of Brian Petra-Simone's lab, where they showed there's not a great linear correlation between fear of injury, fear of movement, and a lot of the gait parameters. But I think Ryan, he broke it into like tertiles, or like broke them into groups. And I think in the high fear group, there was an association, but it's not just global. And so it might be thinking of fear as more of a categorical variable. Like if you're above a certain score, you have a certain good score on the Tampa scale or the ACL RSI, then it's kind of a wash. Like that's not really going to mediate your mechanics, but it's when you hit this threshold where like, oh, these people are in fear, now it's going to modulate their mechanics. So I would probably just think of it more as a categorical effect on their mechanics. So the neural efficiency question is a good one, and that's how we interpret some of our data. It's a really interesting phenomenon where essentially it's a way for us to better understand complexity. So if we took Julie, who coaches soccer and assume has pretty good foot dexterity, maybe played some soccer, and you take me, who never played soccer, so I have very poor foot dexterity, and you throw me a ball and have me try to kick it, it's going to take like all of my cortical activation. I'm going to be at my ceiling, right, to try to do it. That's like the top of my abilities. But she's going to be a lot more neurologically efficient. And so it's going to take her a lot less cortical activity to engage in the same task. So that's usually how it's interpreted. It's usually interpreted as a relative measure. And what we think mostly from the cognitive literature is that it's what enables complexity or higher order activity. So in the intelligence literature, we know that if you're a super smart, intelligent person and really good at like math or something, or you have really good working memory, the reason for that is you have developed this efficiency response for lower level fundamental processes. And so for instance, like to do simple addition for someone who can really do calculus requires less neural activity. That's why they can handle the greater complexity. And then if we apply this to sport, some of the first studies in the early 2000s were in balance and posture studies for different levels of athletes. And there was like 3 or 4 out of Brazil that were just really interesting. They used EEG, and they had these really high-level karate athletes stand on one leg, and they basically almost saw no neural activity because they're standing on one leg and engaging in very advanced activities. Then you had mid-level athletes like fencing and some athletes that are used to being on 2 feet. They have a little bit more activity, and then non-athletes require a great deal of neural activity to stand on one leg. And so we see that for especially the motor cortex and the premotor cortex in our ACL patients, where they require more neural activity, and we think it has to do overcoming a few things. So one is they're integrating a new sensory environment, so that's just going to be more taxing. They have some spinal mediated inhibition, and so your spinal cord tries to knock down the quadriceps, and it seems to shift to use the soleus and the glute max to allow you to have knee extension without using the quad, so you don't have that shear force on the knee. And so it's going to require you to have more neural activity just to turn on your quad. But then if you have that, you're going to hit your ceiling sooner. And so our job as a therapist is to try to restore that neural efficiency. And that's where a lot of the ideas for maybe implicit training or knowledge of results for how we progress our athletes with motor learning can help facilitate that response, and then they can handle greater complexity. The second part to the question, it was will they change their cognitive processing? And I think we're getting to a point now where it does seem like when our ACLR patients, even 6 months or more after an injury, if they are engaged in a dual task or they're challenged cognitively while they're moving, they tend to do a little worse. Their motor performance tends to suffer. And there is some null results in that literature, but most of those are auditory mediated. But it seems like if you have a visually mediated dual task, that tends to be more taxing, which is also what we see in the neurologic data. We see this shift, or we waiting to maybe use vision to help you program movement. And if you think about, maybe not if you see Julie in her clinic, but a lot of standard of care, I mean, they just allow you to stare at your joints forever. And I do think there's a place for it, like we talked about earlier, but you've got to transition them out of it. And so, because if you start to use vision and cognition just to get your knee to move, I mean, how are you going to do it on the soccer field? And so that's just something to think about what you're trying to progress to.
That's great. Great answer. Anything to add? No? Okay. I have a question about force plates. Okay, my question is it possible to pick up a knee-hip ratio discrepancy without dual force plates? How can we observe that in the clinic or make judgments based on with technology that we may have?
Is it possible to detect that without dual force plates or without force plates, or?
Dual force plates or force plates. Like, can we look at this? How someone's doing? I think it would be intra limb loading, and can we assess it effectively in the clinic?
So, we found a pretty strong relationship between center of pressure differences between feet during a squat task and the use of the hip first. So, and I'll describe this in a sort of research paradigm here, but then I'm not gonna presume that you can just directly apply this, because I could see where you could go with it, and I'm not sure that's the true answer. But when individuals did a bilateral squat, we assessed the amount of force under each limb and then their relative center of pressure, or the position of their center of pressure from the heel forward. So the more anterior, so towards the foot, the center of pressure was, the more that ratio between what they're using at the hip was biased towards a hip strategy. So the more anterior that center of pressure was, the more they were using their hip versus their knee. And if you picture that ground reaction force, that vertical ground reaction force moving up to your toes, and if it truly was just a vertical ground reaction force, you would see that it's getting closer to your knee joint center. And theoretically, that means that their external demand on the knee is. So while that relationship existed, the further forward in the foot they had their center of pressure, the more they were using their hip and their ankle versus their knee extensors. It was the importance of this was more profound when it was a difference between feet. Meaning, if I did a squat and came up and I was more in the ball of my foot on my surgical limb, as further back in my foot on my non-surgical limb, then that gave us an indication of this shift in the limb was different on one side versus the other, and it was more biased towards the hip and or ankle than on the other side. So when I think about that, I think, okay, well, let's just make them all, don't let anybody shift forward onto the ball of their foot during a squat. I don't think that's the answer. You have them change that position. They're going to change something else, perhaps, to achieve their goal of not loading their knee. So I don't think it's as straightforward as that. But I don't remember the author, but there's a recent study out of the Legroup group that also saw this this tendency to shift forward in the foot during running, and you can actually raise it to barefoot running or forefoot running is going to reduce the demand. And they found that that individuals after ACL reconstruction actually did that. They had a sort of a more of a forefoot on one side and less on the other, and that surgery side. So, so where they're accepting those forces through the foot may be one small way to assess it. I don't know about treat it, but sort of assess that. And you could do that with single force for sure. And Julie, it sounds like you have a force trajectory overlay, a video overlay over here.
Yeah, I do. I only have one force plate, so I do a lot of stuff single leg, so we're not looking at both sides at the same time. But without the force plate, if I didn't have it, I look a ton at the sides of the plane on what shin angle and trunk angle is looking like on squats. And it might have been the second presentation on ACL study day, I actually showed an athlete who wasn't aware he had such a strong quad deficit coming off of a professional season. But he's doing a split squat jump, and you can just see it. He's very vertical shin, shifted back in his hip on the quad impaired leg, and then much more of a positive shin angle and his trunk angle. And obviously this is going to depend on body limb lengths and all that sort of stuff, but a little bit more of a balanced approach. You can just clearly tell just from shin angle. If more vertical shin, a lot of times is going to be more of a hip strategy. You got to look at what's going on at the trunk too. If more people are more forward shifted at the trunk, that's going to be a little bit more of a hip strategy as well. So I would say looking at athletes from the side, if you have no other technology, or if you got an iPhone and you can just look at some simple shin or some simple angles, just to see what they're doing and just comparing it side to side. That's probably one of the easiest ways to look at stuff.
And Julie's right too with that. This looking at them together in that are they parallel? Are they relatively parallel angles is a good indication as well. If the trunk is more than the shin angle, and I want to say Chris Powers and one of the students has recently did that type of analysis and maybe publishing some of that in that how those relate to that shift away, or the hip strategy, I should say.
Well, maybe you can clarify here, because a question did come in this morning actually about that specifically. So I'll just read it to you. It says, I thought that anterior weight shift increases stress or force through the knee joint. However, based on your presentation, it seems that forces in the knee are less with an anterior weight shift and greater with the posterior weight shift. Can you clarify? So you talked about it a little bit. Can you maybe expand on it just a little bit more?
Yeah. So again, that's just in this experimental test, right? And just if you're to shift forward in your foot, you could be making a ton of different adjustments somewhere else in your body that are going to distribute the load. So that's why I'm afraid to kind of to say this is the answer to a certain, even one particular exercise question. It's more the idea that the point of it is that these guys are doing a squat, a simple task, and they don't look different. And we measure their angles to the best degree that we can at the hip and the knee and the ankle. And there's a 3-degree difference between knee flexion and nothing else, right? And that the only difference that we see, or we actually see a small shift between the limbs, but nothing to the extent of how they're loading their knee. So a 38% decrease in using their knee extensors was explained by a small amount by how much shifted off of it, a large amount in the very small difference in the center of pressure. So my point isn't this is how you should fix it. My point is that they can cheat by making very subtle adjustments that we can't necessarily necessarily observed, and that's only using this in the sort of the experimental squat, task, bilateral task paradigm. So I hate to stop there. That's where I throw it over to Julie and say, yeah, now fix it. But that's more, my point was more of that versus how do you fix it? I don't know.
Yeah, and you have to look at the whole picture, because if I really want to just isolate quads in a squat, really want to isolate or try to isolate quads in a squat, I'm going to have them do a Spanish squat. I'm going to have them do a very vertical shin with a very upright trunk, if not leaning back a bit, to try to increase that moment arm as much as I can. So there's different ways to get at it. Does that look athletic? No. You're going to want positive shin angles and a little bit of a more balanced approach to some of the more athletic stuff. There's not just like one thing. You got to kind of look at the whole system, because, like Susan was saying, if you can do one thing at one joint, you're going to compensate somewhere else. And the task there's so many variables into it. So, yeah, it's complicated.
Yeah, and it's that big Venn diagram too. Like Julie says, if you want to focus on the quads, then yeah, you can get in a position that really focuses on the quads. So there's the quad strength, and there's the combination of spinal level, a supraspinal level deficits that are coming along with the dysfunction in the quad, and the fact that we need to pay attention to that. But then the whole movement strategy part of it is how they're redefining movement in the absence of whatever knee variables they have at the beginning, right? So now they have this movement repertoire that is progressively getting more successful without using their knee as much as they need. And that, that's just the complexity. You get the capacity there, but then are they also then using?
Well, that may reminds me of another question I think is relevant to that, which is like if you're doing something like a dual task training where you expect their performance to decrease, like what's the optimal way to give those cues or give feedback in a way that we're not reinforcing bad performance? How do you maintain a positive improvement over time? What do you think, Dusty?
I treat it just as another progression. So the same way you would like add weight to the squat or the leg press, and when you add resistance, if they totally collapse and you use your clinical judgment, you're like, oh, that's too big of an error. Like, if you add too much weight to the squat, say you like doubled it because you were getting cocky, and they just fall over and collapse, a total failure. You're like, oh, well, I pushed them too far, right? So the dual task training, I think of it the exact same way. You're just adding, like, think of it as neurological load or cognitive load, because when they go back to sport, they won't be able to use their cognition to control their joints as they do in your rehab clinic. So you're just trying to simulate that. And a lot of times it feels a little arbitrary, because you're like, well, why would I have them count backwards? Or why would I have them look at my hands and memorize numbers that I tell them or whatever? But you're really just trying to occupy the neural resources that will later be used to navigate the field. If you can make it more sport specific, all the better. But you're just trying to train an aspect of physiology, and you're not necessarily as worried about the specificity of the task, but of course make it more sport specific. People get pretty creative with it. But if they totally collapse and their squat just suddenly looks terrible, well, then you've made the cognitive task too challenging. You should make it a little bit less. So for instance, maybe if you're just standing there flashing numbers at them, maybe you do less numbers, or it's every other squat, or maybe you have them add, so they only have to keep one number in mind as they go, and they don't have to keep memorizing new numbers. So you can be very creative, and there's a lot of good papers which show progressions and degressions of them. And I can send them to you, Matt. You can upload them to the website. Because it is a little more, you have to be a little more creative, because you're not just adding resistance, because that's like the obvious way we progress physical exercise. So you got to be a little more creative with the cognitive challenge. But your point is to induce some motor error, because you don't want them to move perfectly, because if they're moving entirely perfectly, then they're not really adapting, right? We have to have errors to have adaptation, to have motor learning. So this is, again, where it comes to being a clinician. How much error are you comfortable with? What stage is your athlete in? Like, is it really close to surgery where you got to protect the graft? Maybe you're not going to push them as hard. You're going to be a little more conservative. But getting later, maybe you'll let them have a little bit of an air bandwidth that you're comfortable with, and you give them feedback. And I mean, again, this is why you're clinicians, but that's how I think about it. And I try not to make it any more complicated. It's just another checkbox and progression that you try to do.
I think in late stage on return to the field, not even return to competition yet, but return to the field, that stage gets lost a lot in athletes if they're not in a professional, and even sometimes in college settings, is that neurocognitive load. We have them isolated in a clinic, and then all of a sudden they're supposed to go back into a team setting. So I in our facility, we have them go into small groups around the 5-month mark, where they're at least having to process being around other people, other space, timing stuff up with a group, just small stuff where they don't have complete control over their entire environment. And they got to start processing that. And then the way I simplify it, I do about 4-week chunks if all is going well. Where that first 4 weeks onto the field, it's purely technical stuff, where they're having to process stuff, the environment, but they don't have to worry about a defender. They don't have to worry about being tackled or hit. They don't have to worry about scoring a game or any the outside pressures, and then slowly building up that neurocognitive load and some of the stress that they're going to feel going back into play, but try to smooth that out. So I think the very late stage stuff, we have to make sure we continue progressing that, so that there are errors, like Sophie was saying, and we're always trying to find what is that right amount of challenge. And I think that would do a lot to help with some of these second injuries that are going on.
Yeah, I like that. I like that it just seems pretty simple when Julie says it, but maybe not always thought of like that. But if they're in a group it's a group exercise now. Like there's other things you got to be attending to. I think that's genius.
You're going to think a lot less about their knee in a group setting, than, because I know like at 4 months, my facility, if 4 months, if they're not, a lot of athletes are coming in to get their workouts in, but they may not be seeing me directly. So they have their warm up, they come in, they do their warm up on their time, kind of at their pace. But at 5 months, if they've hit all of their, if they've hit their criteria for things and they're into those groups, well, now, A, you got to show up on time. B, the warm up's going to start together. You're going to be in a group with some other athletes, some other space that's managing that stuff. And that, it's surprising how many athletes say like, wow, that's like, and we will see movement strategies change when they go into a group, because all of a sudden they're trying to keep up with the group, and we still got to make sure we're keeping an eye on them so that we're not feeding a compensation at that point. I just did that this week. An athlete that came back and trying to get ready for into group stuff, and I watched her. The whole session was me watching her, how she's actually moving in the group setting to see if her compensations are coming back, to see then, how do we have to plan the next, few weeks of the rehab.
Genius, because they're going to do that anyway when you throw them back into their team. You're just not
see it. Yep.
Well, this is great. We're through almost all the questions here. There's one neuro-specific question that came up. Wonder what your thoughts are on mirror box training. So you basically obscuring your injured limb, sort of superimposing your healthy limb over top of it. Wondering if that could be an effective treatment strategy for, I don't know, for helping along the process. I love the thought, the look of thinking on Dustin.
Good question.
Wheels are turning.
So I think of it. So originally it was done in hemiparetic patients, right, where you could use a mirror and you sort of trick them, and you could have some recovery moving your healthy limb when you can't really move the injured limb, because the brain will start to think it's the injured limb. It sort of speaks to how insanely powerful the human visual system is and how much we just like depend on it. That's one thing that I think gets missed a little bit. Those studies are fascinating because vision, you'll overwrite all of your other senses based on vision. Like you'll like proprioception, you'll be like, well, clearly, it's not that hand, but your vision is just that powerful. And so I think that's just fascinating. So trying to use that to your advantage to recover the ACL leg is a challenge because the deficits, as Susan talked about earlier, are so much more subtle. Like they're not hemiplegic, right? They have a lot more capability than in the population it's typically used for. I think
they have a big loss of they have a big loss of sensory input, right?
But would you consider that reinforcing this dominance of vision versus helping anything?
That's exactly where I was going with it. Like, would you just, even if you were able to get say someone's a heavy quad inhibition, let's take our like worst case scenario, and you wanted to use mirror trade to show like good quad activity, I think you would maybe do more harm than good potentially in this scenario. It's an interesting idea. I'll meditate on it more, Matt. Think about it. It's a cool idea, though.
Yeah, no, that's cool. Maybe we could do an impromptu one of these if you had a chance to think about it a little bit.
I wonder if you could do it for a more complex movement, like for gait. Now, the thing, you would have to have someone who would have enough of an asymmetry that it would be detectable, which is always a challenge. But I wonder if you could trick them into having asymmetry or trick them into symmetry somehow.
Now, what if you just did something like a VR where you're looking at a person walking with a perfect symmetrical gait, from a first person perspective, so you don't see yourself, your asymmetric walk at all. I mean, that's kind of the same idea, right? Is that you're using the visual system to overpower. Is there any research on that specifically, VR?
Not this specific, for sure.
Yeah.
There's some cool work though where you can use VR for action observation training to do gait or do activities. But a lot of those studies, you're just trying to get people to have like up their gait speed. It's very like global restoration of motor function and not as the nuances we're trying to get. Maybe as technology gets better and it gets more higher resolution and cheaper, that's an option. It's an interesting one.
Yeah, the tricky thing with gait though is that these guys don't have spatiotemporal differences. Their stride length, and swing, all of that it's all the same. You can't detect. That's why it looks good in the clinic. There's just no profound. When you're limping, obviously you got a big red arrow, warning sign there. But after that, these things are so subtle that it's difficult to identify. One thing I wanted, sort of the question of, you use a technology to say in a lot of our research paradigms, we're using a technology and we find a certain compensation or whatever, and then the mechanics underlying that, that then must be the solution to fix that. And like I said before, I try to stay very far away from that because they're very isolated assessment. And I think the solutions, there's a lot of solutions out there. Julie and Dustin are doing a lot of that now. And my sort of fantasy for the restoration of movement in mechanics from the level that you need to have something to assess that is that we have clinically accessible assessments that would fit into, say, Julie's framework. Julie has a framework of at what time do they need to be able to do things, but within that are not overly cumbersome metrics for assessment, that you have objectives saying, yep, you know what, when we pick this sort of key task, asterisk task, that they don't have this pattern. So I feel comfortable that they didn't reinforce it across this period of time. And that what I'm assuming with my exercises and my vision, my visual observation and all of these other pieces that, like Dustin said, the art of this that we have as we're progressing these people through is good. And my athlete is responding. Now move on to the next thing. And that's sort of my fantasy for the use of any of this, the biomechanical stuff that comes out of our research in the clinical world. Fantasy.
Wow. Well, we are just about out of time. I've had so much fun today. I really appreciate the three of you taking time out of your Saturday to hang out with me. Is there anything that like you want to close with, or any thoughts or things that we didn't talk about that you want to throw in there? If now's the time, if you have anything extra.
I would just say thanks for trying to be a better clinician. I mean, you've given up your time for your patients, and this is all part of it. So thank you for that. Everything we do sort of doesn't matter if we don't have you. So thank you.
Absolutely.
Yeah.
Thanks on behalf of the patients for everybody who's tuned in to better themselves. And maybe we spurred an idea where they can go somewhere even above that. So it's awesome.
Yeah.
Stay creative.
Yeah. I think for me, for anyone watching this, if I think just if they tuned in, that's like a bonus. That's they're already doing above and beyond what a lot of clinicians are doing just by trying to learn a little bit more. And if they walk away from this with one or two new ideas or some new research articles to go and look up, I think that's great. My goal is accomplished with putting this together. So. Well, thank you three for tuning in. Thank you to anyone who did tune in. And that's it. Appreciate y'all. Thanks.
Thanks, Matt.
Thank you.